Hey, BC here. Welcome to BC Nephro. Today, I'm going to talk about the next in the series of outpatient dialysis rounds. This part of it is going to be the management and monitoring of patients with acute kidney injury dialyzing in an outpatient clinic. As always, for more information, visit bcnephro.com, link in the description below. Sign up for newsletter. Leave your questions or comments in the either email me at brian@bcnephro.com or leave it in the comments below. So outpatient dialysis traditionally had been for what was referred to as end-stage kidney disease, which was kidney failure that was deemed to be permanent and irreversible. More and more patients with acute kidney injury have required dialysis in the outpatient setting. Traditionally, they had been acute kidney injury dialysis requirement had been only in the hospital. But now a number of things have happened, including a drive toward decreasing the length of stay and more complex patients with underlying chronic kidney disease with other comorbidities that make the duration of acute kidney injury longer. So it is not uncommon to have patients with acute kidney injury requiring dialysis at the time of discharge, post-discharge, and this would be in an outpatient dialysis clinic. So these patients require special attention and monitoring. So there's three things to think about. One is how to predict what the likelihood of recovery of the acute kidney injury is. The second thing will be how to monitor for this recovery. And the third thing is how to decide that, in fact, it is not going to recover, and then change the classification from acute kidney injury to end-stage kidney disease. First, what is the likelihood of recovery? How are we going to decide that? The main factor has to be with the underlying severity of chronic kidney disease. So if someone had a normal kidney function prior to an acute event, they're much more likely to recover, and I would expect recovery, than someone with stage 4 chronic kidney disease that had an acute kidney injury on top of this. So that's number one. Number two would be really the comorbidities. So someone with a lot of cardiac disease, especially congestive heart failure with volume management issues, running low blood pressures to begin with, are going to be less likely to recover than someone without this comorbidity. And the third would be the etiology. So if someone has acute tubular necrosis, ATN, more likely to recover than if someone has maybe an RPGN that was caught late. And if you're fortunate enough to have a kidney biopsy, the kidney biopsy can shed some light on that too, about the chronicity of kidney disease, which specifically is best determined by the amount of tubular interstitial fibrosis and tubular atrophy. So the tubular interstitial compartment gives the best insights on the chronicity and therefore the likelihood of recovery. Now, second, how to monitor for this recovery. So, we typically tell kidney function by creatinine, and the creatinine is a formula to give us an estimated GFR. But in dialysis patients, the creatinine is changing. So if the creatinine is checked right after dialysis, it's going to be much lower. Then it's going to steadily go up to the next dialysis, and it's going to be higher before dialysis and then lower again. So the creatinine is not in steady state, so that's hard to use. Now, of course, the patient needs to make urine to have any kidney function, so that's another factor. So there's a couple of things that can happen. One is you can monitor a 24-hour urine for creatinine clearance, or 48-hour urine in between dialysis sessions to measure creatinine clearance or a GFR. Then you have to figure out which creatinine to use a time average creatinine, and things like this. Can be a little bit complex. You're not sure about the collection, if it was 24 hours under collection, over collection, or things like that. I find these difficult to use for these reasons. What I like to do is I like to monitor the weekly pre-dialysis creatinine before the first treatment of the week. So the first treatment of the week is either on Monday or Tuesday. Trend that creatinine every week. So if you see that the creatinine when they first got to the hospital on Monday before dialysis was 8, and then it's 7, 6, 5, 4, getting down low like that, that's a sign that there's some recovery of kidney function, and a good sign there. And then I find the best way to try to figure out volume status is the interdialytic weight gain. So certainly if a patient has an interdialytic weight loss, that they're diuresing in between treatments, that's an excellent sign. But monitor the interdialytic weight gains to see if they're excessive or nominal, and then add diuretics in there. So then what I like to do, actually, because these patients are difficult to monitor, it's another transition of care, a delicate point where they're still recovering. Are they going to be able to get by without dialysis or not? And then they may have residual chronic kidney disease, need to be followed in the office, and it's very difficult. They need very close monitoring. So what I like to do is I like to wean the dialysis. So if the creatinine is trending to a good level, if the interdialytic weight gains are very, very low or non-existent, I will cut it to from 3 times a week dialysis to twice a week dialysis. Continue to monitor that. Still look good, cut it to once a week dialysis. Still look good, stop dialysis altogether, check labs after a week or two, and then we can get them into the office in this time frame and get this good transition of care there. Now the third thing is how to know that it should be end-stage kidney disease. Now why is this important? Well, the reason it's important really is there's some planning that needs to be going on to optimize the care of patients with end-stage kidney disease. So if someone has end-stage kidney disease, they should not be dialyzing through a catheter. They should be dialyzing through a fistula or a graft. And but if someone has acute kidney injury and is waiting for it to recover, you may not be putting the fistula in at this point. So at some point, you have to make this planning. You have to bite the bullet and assume it's not going to get better. Make this plan to get an access. Also, make this plan to get evaluated for a kidney transplant, get on a kidney transplant list. So those are the main reasons. So the easiest way is really 90 days. So essentially, if they haven't recovered by 90 days, you have to assume that it's end stage. That's not to say that they can't recover after that, but the chance of recovery is so low at this point that you just have to make planning for this. So that's a good rule. Now, of course, if someone has advanced chronic kidney disease before, they have a lot of scarring on their biopsy, all these other comorbidities, it is possible to make that judgment sooner and not have to wait the full 90 days. But if they're 90 days, they shouldn't be classified as acute anymore. So anyways, that's how I approach monitoring of these patients with acute kidney injury after the transition from the hospital to the outpatient dialysis clinic, and then moving them into the nephrology office, chronic kidney disease setting. Any questions, comments, leave them below, and check out bcnephro.com, and see you next time.